Okay, I will share what a few comments. So I put out a request on Facebook for ideas, what people wanted to talk about at this meeting today, and a lot of the comments came down to what happens later. And Michael has already said that there is this proportion of people who have more persistent chronic problems. And he's also pointed out that actually it sounds like maybe people don't go looking that hard for persisting and ongoing problems, at least when it comes to writing up things in journals and in the literature. So I thought I'll share these with you, and I'm very happy for people to jump in and say what they think. Although of course I can't see people's hands while I'm on this screen.
I'll help, Adrian.
Yeah, thank you. So the basic problem is that no one seems to know anything about Sydenham's Chorea in adults. There's no effective medicine, and it's so rare that funds for research don't seem to exist. So that's obviously quite a negative perspective, and that is this individual's experience. Part of the reason we have our charity is that we can fund research, and we have funded the work, partly funded the work that Michael has done, but also previous work. So it's not entirely true that there isn't the potential to do some research. But I think from what we've heard people say is that it's already hard enough to find doctors who know anything about Sydenham's Chorea in children, let alone in adults. Another comment was, well, mental health related issues are very rarely talked about or discussed and not easy to get info on. My 11-year-old was diagnosed 2 years ago, just had a relapse, and I thought they were going to put him in psych. So I think psychiatry, it got so bad at the hospital. So there is this thing of you see these physical symptoms, but it is well recognized you do get these more psychiatric symptoms, and Nadine is really the expert on this. Michael showed that emotional problems, anxiety, irritability, hyperactivity were actually pretty common, but there was a long list of other or mental health symptoms that can happen in the child. And then of course, what then happens going forward?
And I think you made a really important point, Adrian, about saying that the symptoms need reassessed when the Sydenham's gets better, because I know as part of our study where we looked at the 12 cases that we'd have, 2 of the children met the threshold for a diagnosis of autism. Now, autism is a lifelong condition. It's really important you get it right, but actually as they recovered and the Sydenham's settled, those symptoms were no longer present, so they wouldn't have met the threshold for a diagnosis. So it can be really intense, I think, at the point when the Sydenham's is really unwell. So you've got the physical symptoms, but you can also have these really striking psychiatric symptoms of lots of things, from tics to high levels of separation anxiety that then feeds into poor sleep, poor diet. So it's really, really important that you're thinking of the whole presentation and not just the physical side. I think I said earlier, it's really important that the child has someone to communicate with about how they're feeling, whether that's the school nurse or a counsellor or just a member of the family, or one of the health professionals at the hospital when they're going for their follow-ups. It's really important that the child has a space to be able to explore their thoughts and feelings, because it can be really quite scary. And a lot of you have talked about young children. It can be really quite scary if you lose your speech or you lose the ability to feed yourself or to walk. Just having some space to reflect and think about that alongside the psychiatric symptoms that you might be seeing.
And I think you did set up a kind of support group, Nadine, in Glasgow.
Yeah, we set up, we had a little group of parents and patients that we supported. We were really fortunate in Glasgow that we had the liaison psychiatry team. Not every general hospital or children's hospital will have a liaison psychiatry team, and I think the criteria for those teams have changed a lot since I've moved away from the sick kids as well. Like I've mentioned, there's lots of crisis work going on. The age of criteria can change as well. So if we're dealing with 16 to 18-year-olds, it can make it harder for families to get in. I work at the minute in CAMS, or SIPs as we call it, and we very rarely get cases coming through. We have had them, but trying to meet the threshold for community mental health services can be really hard. So exploring, what counselling services are out there, what services are in the hospital is really important. Most hospitals will have a paediatric psychology team as well that might be able to, visit when you're on the wards, but also to signpost you in the direction of appropriate support. The educational psychologist can be really important. They'll have different names throughout the world, but for us, they are the psychologists that go into school and help when children can't attend. We had lots of non-attendance at school or reduced timetables, or children needing to take wheelchairs into school. It was, lots of hindrance for just being able to access education, or their absolute school refusal because it was just all too overwhelming. So having key people in school, like the special education needs team or the educational psychologist, it's really, really important. But you should hopefully be able to get that advice within the general hospital. But if not, you can always phone the local CAMS teams as well for advice.
Michael, I think you've got your hand up.
Yeah, I wanted to say something about adults and long-term difficulties. I think there's something very difficult about a condition that can fluctuate. Services for adults tend to assume that you are who you are and that's how it is. And outside of maybe epilepsy and psychiatry and one or two other conditions, there isn't really an expectation of things fluctuating. But that's exactly what happens with a lot of people who have chronic Sydenham's symptoms. But I think the key has to be this word rehabilitation that Michael used a bit. And the best models for rehabilitation are probably in brain injury. And you can almost think of what happens to a brain with Sydenham's when, the problem doesn't go away. Whether you could find an injury on a scan, you might well, but you might not, but it would be minor. But you are left with someone who has got something different about the way they're made as a result of their illness. And that requires lifelong rehabilitation for some individuals. Unfortunately, not very many. The mental health part is really important, but actually it's the whole person. And I can only think that using that word rehabilitation with professionals can sometimes tune in a way of thinking which can be helpful. But there's no one service that sits there that has the skills. Unfortunately, it's about each family putting together around an affected person what they need. That said, we've talked a bit about chronic treatment, and there are lots of ways of trying to treat chronic conditions. and it's knowing when to try something new and when to decide to stop, given the side effects of drugs and the problems there can be. So having a medical guide through this process is important. But I don't know whether Michael has thoughts from the research about the really difficult chronic conditions where people have paralytica type symptoms, are quite disabled, as well as the mental health side, which I think I can see how mental health services should be able to grapple with if they can get their heads around rehabilitation. But from a neurological point of view, there are children like we were hearing earlier who are still unable to walk 2 years later. And what can be done there is a very interesting challenge.
Yeah, I'm not sure I have anything to add beyond. Definitely, it's a rehabilitation approach, isn't it, and a multidisciplinary approach. I've never managed any patient like that myself, so I wouldn't be speaking from experience. Well, not a patient like that with Sydenham's Chorea, but extrapolating from other illnesses. Yeah, intensive rehabilitation is often needed in a setting where that can be provided on a daily basis, sometimes for a period.
Thanks, Michael.
So then it's sometimes the parent needs to be that facilitator of that team of experts that's around your child, and then as you become an adult, it, whilst you're having these relapses and times of being unwell, trying to hold that coordination together can be quite tricky, I imagine. So it's about having a network and people around who recognize when things are getting a bit tricky that can step in and help. Because when we talk about a team of experts, we could be talking about a neurologist, we could be talking about a speech and language therapist, you might have a counsellor. There's lots of different layers of treatment. It could be the cardiologist, it could be the physiotherapist. There's lots of different specialists that feed into the treatment of Sydenham's Chorea to have a successful recovery when it is chronic. That takes a lot of coordinating and takes a lot of time. So I know from the Facebook group, we see a lot of parents end up, sadly having to give up work because they need to focus on the care needs of their child while they're trying to coordinate all of this. And it can be exhausting at times because you're knocking on doors and not always getting the answers that you want. Or you finally coordinate together and you have that success, but then as soon as that team pulls away, things and relapses can happen that set you back. Then trying to get back into services and trying to get those resources again can be really tricky.
I believe, Stina, you particularly had issues with trying to get the relevant support or the appropriate support. I don't know if
yes,
you wanted to add something.
No, it's just surprising how different to get people to cooperate, the doctors. So I think we have received some good help in some cases, but then when the actual healthcare is supposed to be carried out, it doesn't work. It's really to get people to cooperate. And I think as a parent, you have to be very strong and you have to keep fighting, and it's just difficult to never get any recognition. And I think it's so strange, and then you get different diagnoses, you get different types of treatment. It should be easy, and I haven't had the feeling that people are cooperating to. I think it should be of the interest of the child, and number one should get the child back to healthy and to get them back to school again.
Mm. And I think, Leisha, your story touched on that a little bit as well. Just the frustration between the communication between services, and that is absolutely the reality. Each team will have their funding and their aims and objectives that they need to meet to achieve and successfully keep that funding from the government, and it becomes an absolute minefield of what you're navigating. And I think that does get a lot worse as you move into adult services. The services seem to separate even further. And a simple example of that would be, even autism and ADHD aren't managed together in adult services. They're managed very, very separately. you know, where in children they all come under the umbrella of children's mental health services. So it's really tricky sometimes for parents and children and families to understand that, because we as professionals don't always understand that. Nikki? Oh, sorry, Alicia, it was first there, I think.
Yeah, on that, it was very difficult for us. We had to. The only way we got it was going private, and you know, God forbid if we hadn't had the money to do that. And I know a lot of people don't. I never would have been diagnosed, and I've been told by a lot of people, a lot of doctors, that it was all in my head. Which even now today I carry that with me. I think, oh no, like get over it. You're just making it up, and that's a really scary, difficult thing to do, because I genuinely, for many, many years, thought, like, I must be such a terrible person to be making this all up and seeing what this is doing to my family. And I was told as well that it was FND. I've been told that all girls before the age of 16 have seizures. I've been told, oh, it's the stress of your GCSEs. Like you're putting it all on, you're making it up a lot of times, and that's very hard to hear. And you know, thankfully I have a family who didn't believe that, but I'm sure in a lot of cases people do believe that and just, you know, go with that. And I think it's very difficult because there's not a lot of research on Sydenham's chorea and there's not a lot of awareness, but how much of that is, it's a vicious cycle, because a lot of people probably are misdiagnosed and a lot of people probably have Sydenham's chorea but don't get diagnosed, therefore there's no awareness, therefore the cycle continues. So yeah, I just wanted to add that in, and thank you so much for doing stuff like this. And it's really important to try and, you know.
Yeah, so when she was 15 and she got diagnosed with FND, basically that really did traumatize her more. And so we just left the NHS for probably, for 6 years until last year. And then I read up about pandas again. So when she was 15, we asked for a pandas test. And this is how we ended up finding out she had Sydenham's chorea. And the doctor said, no, it's not that.
We've lost you, Alicia. Hopefully they'll come back.
Yeah, hopefully they'll come back.
Yeah. Nikki? Oh, there you are. We lost you there. We lost you. Hi there.
Hi there. Yeah, we were treating her for Lyme disease, and we were doing herbal and various other things like that. And it was only a year ago that I got the pandas test done, and then I found Dr. Ubi on Facebook typing in pandas, and then we went to him, and that's where we've ended up where we are now.
Yeah.
So try to speak quickly.
That's okay. Thank you for sharing. Nikki? Oh, you're on mute, Nikki.
What I was going to say is, I think once you've got the medical side sorted, and obviously your child on medication, it is also asking the questions about what happens after, like getting Gracie back to walking again, speech therapy. But you've got to keep asking the people within the hospital. I mean, this was all new to me, like it was to them. But yeah, when I see now the treatment, what I've asked for Gracie, for physiotherapy, because obviously her arm movements and her leg movements, where to get her back to walking, get her out of a wheelchair, speech therapy, physiotherapy, neuro, whatever. We went to Oxford, so they did tests, because I was concerned that obviously because it affected her brain, did it have any impact with her learning? Because Grace's mathematical side really deteriorated. Was it a math side of her brain that was also affected with Sydenham's? So I pushed for every possible test, going, just to make sure that she was 100%. And I think that's what you have to do, just push at everything. Yeah, if you don't ask, you won't get. So you have to ask.
And one of the reasons we designed our information leaflet was to share with schools. That was one of the reasons we
Absolutely.
designed it, was so that you could go into school and say, look, this is what it is. This is what we need support with. Because I think sometimes schools will think, well, they've been in, you know, in primary care and in a hospital, and they don't get the impact on them, even just from a tiredness perspective of needing some reasonable adjustments to their school day so that they can successfully manage and successfully get back to school. So we're more than happy that that's there to share. And you know, the lovely team in Italy have translated it and use it as well, which we were very, very honoured about. So I'm aware of the time, and I'm aware that we were moving on to questions and answers with Dr. Morton and I. Is there any questions out there that you were really wanting to ask when you signed up for this event? Or you really wanted to share with the group? Katie?
Hiya. The only thing that I wanted to know is whether, because I tried to find studies and that about Sydenham's, and as we all know, there's like nothing that actually exists. I tried to make use of my uni database as well. And even then it's like really limited what's actually on there. But I wanted to know if anyone knew, like, if there is any links between like having Sydenham's as a child and then ending up with some kind of autoimmune disorder. Because basically I've had like pain since I had Sydenham's as a kid, and we were sort of brushed off for like 20 years. And it's only really recently that people have started taking an interest, and it's only since then that I've had the diagnosis. But I just didn't know if anyone was aware of any other sort of studies or any patterns of other adults that have ended up with something similar, basically.
Michael, are you wanting to offer some thoughts to that, or?
Yeah, I think there is an association that people who are susceptible to Sydenham's, there must be genetic factors there. We don't know what they are, but they're probably shared genetic factors with other inflammatory conditions. I think antiphospholipid syndrome is something that I've seen in association with Sydenham's. So I think it's definitely plausible that there are associations. And if you ask about the family history of patients with Sydenham's, that they are more likely to have a family history of inflammatory conditions than a random person as well.
That's lovely.
Oh, brilliant. Thank you for that.
Thank you. Thank you, Michael. Stina?
Yes, hello again.
Hi.
I'm just wondering here, when it was mentioned regarding pain, are there any experience of how to treat this? Because my daughter has severe pain in her joints and generally in her legs, and also, of course, headaches and stuff. But I think the pain in her legs is what she's complaining mostly. Sometimes big joints, and then sometimes the smaller joints are fingers and hands, but the legs are quite severe pain.
Mm.
Any particular recommendation for medication or anything else that could
Does
help
she
her?
just take over the counter paracetamol and Brufen? Just
Yes.
yeah,
Yes.
yeah, and it doesn't seem to.
It makes it better, but I think she's still in pain and have inflammation. So just if there's anything else you would recommend.
So part of me would say asking for physiotherapy as well, I think is really important.
Yes.
There's the physiotherapist and there's the occupational therapists. I think they can always help, you know, if you're not wanting to rely on medication alone.
No.
And my other thoughts would be obviously having someone to talk to about how she's feeling, because I know when you're feeling uncomfortable, when you're feeling in pain, having somebody to talk to and to share that with can be helpful as well, because distraction is one of the biggest things that can help, but so is communication. And obviously if she's sleeping well as well.
During the night, but it's difficult to relax, and I feel like the pain is making it difficult for her to have movements, and therefore she doesn't like to go to physiotherapist, because I've been trying to take her to physiotherapist, but she always complained the pain is too bad, so she doesn't want to be there.
Okay, Michael Morton, I'm going to bring you in as well.
Yeah, I suppose I just wanted to say that we tend to forget when we talk about Sydenham's career that rheumatic fever gets its name because of rheumatic pain, and the original condition presented with pain, and then people began to see the association between pain and Chorea and pain and carditis, heart disease. And what we now know as rheumatic fever grew out of a historical process of linking these things together. So we have to think about pain in this story. And I suppose pain management is a very skilled task, but it starts by understanding that pain is part of something. But that doesn't necessarily mean that there's a something that can be treated other than the pain. And this is the real challenge with pain, that it's a sign of something going wrong. But once it becomes chronic, the treatment is often not trying to treat the underlying cause, it's trying to manage the pain. And pain management can be a very complex task involving all these things Nadine's talking about, from movement to conversation to medication, basically rehabilitation approaches again. So it's disentangling what can be done about the Sydenham's story part of the pain, and what can be done about the pain that is now here, as opposed to maybe the pain that was there when it all began, because pain can get very stuck. So it's a rich and complex world, and I'm sorry I can't be more helpful, but I think the main thing is to keep a very broad approach and be open to whatever helps.
Thank you, Michael. And Annie, we'll go with Annie with our last question before we move to closing.
Yeah, it's not actually a question. It's just I just wanted to tell Stina that Amanda, her pain got really much better when she got IVIG, and now after 1 year with the IVIG every 6th week, we now reduced her NSAID in half, and her pain isn't coming back. It's just much better. All her limbs, the pain in the limbs are so much better with IVIG. So I hope you get the same results.
Thank you. That sounds really good. We have actually really tried. We have tried it before, and that's what happened the last time. But I stopped it, and then the pain came back. So she was in movement, and she was feeling quite okay at the beginning of this year. But now we haven't had IVIG for 5 months, and now she's in severe pain again. So I hope this will bring her back to where we were in the beginning of the year.
And I think the key thing there, just building on what Michael was saying, is pain can change. So sometimes it'll be that, that the feeling of pain, but pain is a really broad thing, and it's sometimes understanding what is the pain that's being described, and particularly in children that can be tricky, because pain is an expression of distress. Sometimes it's a way of saying, Mommy, I'm not okay. Without necessarily maybe having that intense, strong feeling in the body.
But I can feel her joints. It's definitely actually complaining about the joints, and I can feel that they are soft, so there is a joint problem.
Okay, that's important. Okay, thank you, everyone. Adrian, I'm going to move on to you for closing remarks. Is that okay? Yeah. Annie, did you have another question? Oh, no, that's fine.
Yeah, actually,
Go on. Sorry.
I just have one.
Okay.
Have anyone noticed a problem? My daughter, she has severe problem of speaking for herself. She turns to me, she have this separation anxiety, but she's in certain situations, especially meeting doctors, she's like a stone face, no expression. And I'm afraid that they're going to start thinking that she has autism. That's not the case, because it's, it doesn't differ in that way in autism, but it kind of scares me. Have you had that experience that they just can't? She can tell me, I want to speak, but I can't. It's like a blocking.
It's really, really common, really common. And our approach in liaison would be that Dr. Morton would take me along with him or one of the other nurses. And, you know, you would have your first session together, but then the expectation was that we would separate and come back at the end. So then your daughter would get time with the nurse or Dr. Morton, just depending which way we and the parent would spend time with the other. And then we would come back together at the end to agree a plan from both sides of you know, the importance of everybody's opinion and expectations. But I can't stress enough that communication is really important. And in liaison psychiatry, we didn't tend to put labels on things. We didn't tend to talk about separation anxiety and anxiety with the children. It was more just that they had this space to explore, and it was a confidential space where they could explore. So sometimes we might have been, you know, I remember one of the other nurses very much would play games and be very active. I tended to use pencils and colouring and some of that non-directive approach to just exploring how they were feeling. Each session might be different. I could have went into a session with lots of, you know, theory and books and ideas and come out with a totally different session. But the main thing is about that. It's that protected space and just allowing the child the time to have a voice. Sometimes then I would need to be that voice when we went back in the room with the big scary doctor to be able to communicate. Or sometimes they didn't want to let their parents down by saying how they were feeling. There's lots of things that can be going on in the dynamic of the room, but I do think it's really important that a child has somebody who they can communicate and have some communication with away from maybe the doctor and the parent. And for parents, that can be a scary thing, a really scary thing, to allow someone else to you know, speak to your child and not really be 100% sure about what's being said. So there's an element of trust that comes into it as well. Adrian.
Yeah, I can see people still have hands up, but it is nearly 12 o'clock. So I think you can still put things in the chat, or we could move things to the Facebook page. I'm sure there's other things that people want to say. I know Sadiq had to leave and he's had experience of chronic pain with his son. So just to say thank you to our speakers. Thank you, Nikki, so much for sharing your story. Thank you, Michael, for your presentation, but also all of that hard work you've been doing. Feels like the last 2 years, maybe more now. Thank you, Nadine, for sharing. And it's been a real pleasure to see you all here and to hear your contributions. And I wish you all the best for the future. And please do stay in touch.
Thank you.
Thank you so much.
Thank you so much. Bye.
Thank you.
Thank you.
Bye.
Thank you. Bye.
Bye-bye.
And that's a wrap. Yeah. That's great. Right. Thank you, Adrian.
Have a good day.
You too.
Bye.